Hello, everybody. Thank you for joining today's Resident Education Lecture Series. Today's topic is multiple sclerosis, confidently making a diagnosis and recognizing mimics. All participants are muted. If you are having any technical difficulties, please disconnect from the webinar and reconnect. For any questions, please use the Q&A feature on Zoom. We will answer them after the talk, but feel free to ask them during. Joining us today, we have Dr. Suma Shah, a fellowship-trained MS specialist and associate professor of neurology at Duke University School of Medicine. She serves as the program's director of the Duke Adult Neurology Resident Program, as well as the associate director of clinical care, and the regional director of the Regional MS Center of Excellence for the Derma VA. With her today is Dr. Andrea Linares, who is currently a third-year neurology resident at Duke University Hospital. She has an interest in medical education and currently is part of the medical educational leadership track. Additionally, she serves as a guest lecturer for the Advanced Clinically Centered Education in Spanish course at Duke University School of Medicine. Following residency, she'll be staying at Duke to pursue an MS and Neuroimmunology fellowship. Dr. Shah and Dr. Linares, I am turning it over to you, and thank you for joining us.
I am so excited to join you all here today for this webinar for a topic that I can probably speak for both of us is near and dear to both of our hearts. So without much further ado, we'll go right ahead into today's lecture. And before we get started, these are our disclosures. Just so you all know, please feel free to ask questions throughout our talk. Both Andrea and I like to teach very flexibly, which means you ask questions as we go. We're happy to stop and clarify things if something doesn't make sense or sounds different than what you've heard before. But here are our objectives for today. I hope that in the next few minutes, you will all have a really clear foundation of the history and diagnostic criteria of MS. And that'll help us leap right into what the typical clinical and radiographic presentation and features of MS are. With that foundation, what we're really hoping to do is go into some of the common mimics and how to differentiate them from multiple sclerosis. So, in order to do that well, first, what is multiple sclerosis? I think the simplest way of summarizing MS or multiple sclerosis is that it is a chronic, complex, inflammatory and neurodegenerative condition that affects the central nervous system, which involves the optic nerves, the brain, and the spinal cord. In the majority of patients who are living with multiple sclerosis, it's characterized by relapsing events, new episodes of disability that come on over hours to days and then remit on their own time. And it typically, according to the textbooks, affects folks who are in their 3rd to 5th decade of life. What's interesting about this disease is that it has so much complexity, both from epigenetic factors like the environment, from genetics themselves, as well as lifestyle factors, things like smoking. And knowing all of that, you can see this lovely diagram that Andrea has put together here. There's an interplay amongst what a person's individual predisposition may be to developing MS and what they encounter throughout their lives that becomes the perfect storm for someone to develop multiple sclerosis. When thinking about the diagnosis of MS, I think it's important to take into consideration who it typically affects. Over time, we've noticed that there is a gender predilection where women are more affected than men at a ratio of about 3 to 4 to 1 most recently. Previously, and even in textbooks that were written about a decade ago, you might see numbers of 2 to 1. And so this gender skew is increasing with time. Currently, there are almost 3 million people living with MS worldwide, and there has been a long described latitude effect of MS, where the farther north you get from the equator, the more likely it is for that population to have people who are living with MS. And this diagram here, I think, reflects that well, but it also taps into some of the absences of knowledge, the gaps that we have when it comes to MS care in certain portions of the worldwide population, where the gray is just unknown. So to set our foundation well, what I'll do over the next few slides is go through the diagnostic criteria. I'm sort of a nerd about MS, and this topic excites me. And so I do think it's really important to understand that background of MS and where we've been so that we can better elucidate what MS is and then better recognize what it isn't. So the story starts in the 1800s with Charcot describing this triad of nystagmus with a tremor in reaching for things, intention tremor, and then scanning speech. And for those of you who are excellent localizers, you're probably already thinking, this is probably posterior fossa infratentorial of some sort. And that's exactly true. Andrea will go into in a few minutes what that might look like on imaging, but that's what he was describing, and that set a little bit of a rocky foundation of what multiple sclerosis may be. It wasn't until almost 100 years later that Allison and Millar then went forward to try and put together some version of a clinical criteria for diagnosing people with multiple sclerosis. In between, in those 100 years, we had described sclerose en plaques in the French medical literature, all based on autopsies and brain pathology specimen. Allison and Millar describe these categories of MS, of early and probable and possible, to describe the experience a person living with MS may have with what kind of neurologic symptoms they were experiencing. But it wasn't until almost another decade later that we first started to foray into what a standardized criteria for MS diagnosis looks like. It wasn't until this Schumacher criteria in 1965 that we in the medical field described what a relapse is. New or aggravated symptoms that last for more than 24 hours at a time in patients who are somewhere between 10 to 50 years old. But this description is what really started to lay the foundation of that one sentence that we all associated with MS, which is that dissemination in space and time. Almost 2 decades after that is when Poser came up with a criteria to better include oligoclonal banding, which had been described in the decades before as being more associated with multiple sclerosis. I'm trying to pick my words carefully because you'll hear us say over time that those oligoclonal bands, as helpful as they were in an era before MRI, may not have been the whole picture and certainly not specific. So fast forward to 2001. Poser's criteria came out a year before the first commercial MRI was available, and MRIs revolutionized MS diagnoses. So the McDonald criteria came from this consensus committee that got together, and I believe it was London in the early 2000s, to first put together a criteria to facilitate the diagnosis of MS throughout the spectrum of disease. It was here that clinically isolated syndrome was described. It was here that MRI was put into the criteria. And it was really with these McDonald criteria that we've had iterations over time that have allowed us to be flexible to the new medical kind of interventions and diagnostic capabilities that we've had over time. And it's been really fascinating as an MS specialist to learn these criteria. Just as a bit of history, I was in my fellowship when the 2017 McDonald criteria came out. And it's fascinating as someone in neurology to be part of a field that is so ever changing and really actively and intentionally looking at what is the best way to identify our patients so that they get the care they need. So a little bit more about those McDonald criteria. You've heard me mention there have been several iterations. In fact, there are current committees underway that are about to again put together the newest iteration of these criteria. You've already heard me say today, dissemination in space and time, right? That's the age-old statement that we use to really clinically define what multiple sclerosis is. I'm going to take a big step back, away from the diagnostic criteria, but allude to a little bit of them by saying that MS, first and foremost, is a clinical diagnosis. That's where row number one comes from in these diagnostic criteria, and that hasn't changed in decades, which is that if we as clinicians hear a story that suggests that there is dissemination in space and time, and examine a patient and find findings that may occur at one examination and then again at a different time point with different neurologic findings, we don't need to do anything else to diagnose someone with multiple sclerosis. Now, in today's day and age, we've got MRIs, and we really like to have some of that objective evidence that we can't always get on examination, because as we know in the central neurologic space, more than one thing can look like it's MS. So for that reason, rows number 2 through 4 exist, which is where we bring in additional clinical data in the form of MRIs or more recently in the 2017 McDonald criteria, in the form of CSF sampling and oligoclonal bands to uh, really help cement the fact that someone has isolated central nervous system specific inflammation going on. Another interesting bit of history is that there has been criticism, and the McDonald Criteria Committee has really responded to this over the years, where in 2001, the McDonald criteria was so heavily dependent on MRI findings that it almost seemed to ignore or devalue those oligoclonal bands that had been long part of the diagnosis of MS. And back in 2005, they came back and then they were taken out again, those oligoclonal bands. So they've sort of been part of the history of multiple sclerosis diagnostics that have been woven through time. And I think where we currently stand is based on the best, most recent data, which is they have a role. They aren't always needed, but it is important to recognize that if there is a tiebreaker that needs to be made, they can be helpful in figuring out whether someone has inflammation that's more specific to the central nervous system. So those are the diagnostic criteria, but what does that actually mean or look like? Well, when it comes to what a person is living with when they are diagnosed with MS, these are the current classifications we use. I used the phrase phenotyping earlier. All that means is we're describing what we see, right? I mentioned that MS is a really complex disease. And because of the interplay of everything a person comes into contact with, including their own genetics, we can't always predict that someone's story and lived experience with MS will follow any of these graphs. But I'm going to split it up for you all. On the left 2/3 of the screen, there is both relapsing remitting MS and secondary progressive MS. I'm going to lump those together. In today's day and age, we think that almost 85 to 90% of the people who are living with a diagnosis of MS have one of these two subtypes, the majority being diagnosed with relapsing remitting MS at first, which is sort of what it sounds like. Initial relapses, characterized by new neurologic disability that worsens for at least 24 hours and takes often 2 to 4 weeks to get better on its own if it's not treated, followed by episodes of remission. And what I do like to point out, particularly to my patients, is that remission doesn't have to be back to where they once were. And the longer that the body has been subject to inflammatory relapses, the harder it may be for that remission to come all the way back to their prior baseline. And I think that really suggests the sense of accumulated disability that can happen with the more relapses a person's brain, spinal cord, optic nerves accumulate with time. Secondary progressive MS is thought to be sort of a later stage of that, where there may be fewer relapses, but more of this chronic progressive course. There are new phrases being used in the MS field, such as smoldering MS, to really denote some of that neurodegeneration and progression that may happen in the absence of a person having new clinical change or new radiographic change, really the only objective ways we have to test for that. But as folks say, 5 years from now, I was not using this cane as much as I did, and you're looking at them and their exam overall looks the same and their MRI looks unchanged, I think that secondary progressive part of MS is important to recognize. Completely separate from this is primary progressive MS. And we like to lump them together because radiographically, they may all look exactly the same. Andrea will share with you more what exactly that looks like. But for primary progressive MS, the way I feel more confident about this diagnosis is by listening to the patient. Here, I'm generally hearing a story of weakness, heaviness that started and smoldered and got to the point where it started to impact someone's life. More recently, there was a woman I saw in her mid-40s who's been a runner all her life, and she marathons. And with her marathon training buddy, at mile 6, the buddy turned to her and said, "Are you okay? You just seem to be slowing down more." And then she went to the beach with her family. And going down the steps, she noticed that her right leg just seemed heavier. And when we went ahead and got imaging on her, which one of her orthopedic neighbor friends ordered, her spinal imaging showed that there were lesions. That's sort of the story we hear. It's not this big bad event that puts people in the hospital. It is this one area of heaviness, weakness, disability that progresses to the point of becoming noticeable or functionally limiting. With that, one of the newer ways of sharing this classification is something called the topographical model of MS. And many of you may be familiar with this, but both Andrea and I were chatting a few days ago how much we like this model for really kind of depicting MS more than this 2D up and down relapses and progression model, but to make it more dynamic. And so I'll walk you through what this model shares, but I encourage you all on your own time to seek this out online to watch the video, which I think does a lovely job of this 3D rendering of this dynamic process. But just so you all have an overview and knowledge of what this topographical model by Dr. Krieger depicts, there are 3 parts. There is the surface of the water. You can see this little rectangle here. There is the volume of the water, and then there is the pool floor. And you can see these kind of conical things that are like stalagmites, right? They're areas of disability that have impacted the central nervous system, the pool floor. And what the general view of this model is that the person's threshold for compensation is that pool water surface. And over time, because of neurodegeneration, because of aging, because of lack of compensation, that volume of water decreases. And as time goes on, what may happen is that clinical threshold, that pool water, may be at a certain level where all of these areas of inflammation are under that surface. But as time goes on, the pool water starts to sink. That clinical threshold starts to drop. And then things that were previously underwater start to rear their ugly heads, start to show up above the surface. And I think what this depicts is a lot of the challenge that we have with MS, which is the M. By the time we make the diagnosis, many of our patients have multiple lesions. And they look at us bewildered saying, well, I never felt this. How did that happen? And I think what this model does a beautiful job of is kind of showing that the human body can handle a whole lot. The central nervous system can handle a whole lot before getting to the point where the straw tips things over or that pool water is breached. Again, I encourage you to take a look at the video, and they do a far better job of explaining than what I may have. But I'll leave you all there with that history and background of the diagnosis and classification and turn it over to Andrea for walking us through the clinical presentation. Andrea.
Thank you, Dr. Shah. So to first begin, I want us to kind of appreciate that MS diagnosis can cause a variety of symptoms, and that is usually why it makes it so complex to formally diagnose. Normally, we see patients in the age range of like 20 to 45 that will sometimes develop a certain symptom and use the internet or other sources to come up with a diagnosis themselves before seeing us. And usually MS is a very common theme that they come in with. So our job as a clinician is to utilize both our clinical evaluation with radiographical and other ancillary testing in order to be able to really support our diagnosis of MS appropriately. So to begin, no matter where or when the symptoms, or when or where like the symptoms develop, they typically will actually follow a specific time course. They develop in a subacute manner. So the way that works is the symptoms start over hours to days. Then they will kind of plateau over some weeks, as we see in the image, and then improve after weeks to months. So using our history as part of our exam to ask about any past symptoms that follow this certain time course will be really helpful for us to put everything together. When it comes to the actual part of the physical exam, we really get to put on our neurology hat and localize certain symptoms to the central nervous system. Given MS affects mostly the white matter tracts, there have been established specific regions in the brain that are commonly affected and therefore can cause specific clinical signs. So these are optic nerve involvement leading to optic inflammation, for which patients usually complain of having pain with eye movements, a loss of decreased sensation of their vision, or even double vision. And I'll talk about this in the next slide. But other commonly affected regions include the brainstem, specifically the cerebellum and the cerebellar peduncles, that would lead to like incoordination and be seen as ataxia. And then in the brainstem, we can also have MLF being affected, leading to the classical internuclear ophthalmoplegia and nystagmus. When we move down into that spinal cord area, we can start to see patients develop transverse myelitis, which will usually present as having sensory changes, as well as an electrical shock sensation down the back when they're moving their neck. And this is what's commonly known as Lermite sign. And then lastly, as Dr. Shah alluded to earlier, of her patients having these symptoms that worsened or became more prominent in the heat, there is a certain phenomenon called the Utah phenomenon, which is when these symptoms come around when there is heat exertion. Next slide. And then we're going to, these will highlight everything that we just talked about, that optic nerve, the brainstem, the cerebellum, the spinal cord. So what is optic neuritis? There are specific, like I mentioned, clinical criteria, but optic neuritis is actually one of the very clinical symptoms and is present in about 20 to 25% of cases of patients presenting with MS. It's caused by inflammation of that myelin sheath we have around our optic nerve. And this leads to specific symptoms that the patients will develop, including like that decrease or a loss of vision, unilateral pain with eye movements, that loss of color desaturation, which as we can see in this bottom left image, the red card does not look as sharp and red as a patient being affected with optic neuritis. And additionally, on our exam, we can appreciate a decreased visual acuity or an RAPD, which is a relative afferent pupillary defect. And this is due to the inability of that pupil to constrict when light is shown into it using our swinging flashlight test, secondary to the optic nerve being damaged. Usually the long-term sequelae of optic neuritis is incomplete resolution of the symptoms, and those patients will also develop over time optic nerve pallor, and on OCT measurements will have this nerve thinning. Next slide. So when it comes to thinking about radiographic findings, as Dr. Shah mentioned, the McDonald criteria has undergone a decent amount of revisions over the years, but it has been helpful for us to really have further support to appropriately diagnose a patient with MS. Patients with MS for clinical history alone with 2 clinical attacks, we don't always need imaging, and I want to be able to emphasize that. However, in most patients, MRI can be helpful for us to really obtain an appropriate diagnosis using what we call the dissemination in space and the dissemination in time, in order to also help us appropriately exclude other etiologies for the patient's symptoms. So when we think about dissemination in space, it is characterized as having more than one lesion in at least 2 of the following 4 areas: juxtacortical, periventricular, infratentorial, and the spinal cord. As we will see in the upcoming slides, these lesions are usually small, ovoid, hyperintense lesions. When it comes to dissemination in time, the goal is to be able to prove that there have been at least 2 different time periods when there has been active inflammation or demyelination. And this is used by gadolinium enhancement. So additionally, we can also use a combination of asymptomatic enhancing lesions and non-enhancing lesions to also prove dissemination in time in just one imaging. So for the next slide, it looks like, so dissemination into space. So to further be able to prove our dissemination in space, here you will see the 4 areas that the McDonald criteria outlined. And as I mentioned before, going from left to right, we have the periventricular, juxtacortical, our infratentorial regions, and our spinal cord. So to delve into each one individually, for the next slide, we're going to start off with periventricular. So as the name implies, this means that this is a lesion that has to be adjacent and touching that ventricle. They are round, ovoid, and pretty well defined. And the lesions usually will follow that kind of perivenular distribution. So as we can see here, we have an axial representation where we have hyperintense lesions right adjacent and touching the ventricle. And then what I really like is these sagittal images where we have our typical and very classic Dawson fingers. that kind of like looks like the outpouching of those ventricles, and that is very classical for MS. For our next slide, we're going to talk about the juxtacortical lesions. And these also follow the rule that they have to make contact with the region. So this means that for these lesions specifically, they have to be adjacent to the cortical area. There cannot be any normal white matter in between that lesion and the cortex. The reason is there can sometimes be imaging that can trip us up, or calling it subcortical. But when there are vascular causes for having subcortical, we normally will see kind of a white matter, since the U fibers that are right adjacent to the cortex have a really rich blood supply. So they are not affected in ischemic causes or other causes. But when it comes to MS and demyelination, having that adjacent touching cortical lesion is very classic. For the next slide, we're going to talk about our infratentorial region, which is sometimes, I think, for us residents, one of the hardest approaches to take when it comes to localizing, because of how many tracks and how many different clinical presentations we can see in our patients. But when it comes to this infratentorial regions, this includes the long white matter tracts, so the cerebellar peduncles, the cerebellum, and as we can see in our images, we have both axial images kind of outlining involvement of the brainstem, especially like the cerebellar peduncles, and then we also have sagittal views where we can see that those very small ovoid hyperintense lesions on imaging that are classic. And then for our last region that we have the spinal cord. So for spinal cord lesions, they still follow that same pattern in MS, which are usually short, less than 3 segments, and they are normally located more peripherally. So as we see on the sagittal T2 and then the axial comparison, they're very wedge-shaped, and then they are more so lateral, as you can see the arrows pointing to it. So for the next slide, we are going to start talking about what does dissemination in time mean. And I know as a resident, initially, it was really hard for me to try to put 2 and 2 together. But the way I like to think about it is that when there's an acute inflammatory attack on that white matter, there's disruption at the cellular level that will ultimately lead to a breakdown in that blood-brain barrier. So when there is active inflammation and we insert the contrast, we will see contrast extravasation. So if you are concerned about an active disease, performing an MRI with contrast is really helpful to be able to really classify how acute or subacute or chronic this is. And as we can see on these images, there's a very classical contrast enhancing pattern that we will see in MS. And this is an incomplete ring enhancement. The reason that we like to emphasize this so much is because this pattern of ring enhancement can actually help us lead us to MS or lead us away from it. Things like malignancy or infection normally have more so of a complete ring enhancement. And then in MS, when we think about meeting dissemination in time, we must have at least 1 active enhancing lesion, or if we have 1 MRI that has simultaneously enhancing asymptomatic lesions and non-enhancing lesions at the same time, we can also meet that criteria for dissemination in time. So for the next slide, the big question is, why is it then so important for us to be able to make an appropriate diagnosis, especially in MS? There are multiple reasons. The first one is, by being able to really diagnose early on, we can start treatment of disease-modifying therapy early on as well. And this can actually slow down the progression or reduce the frequency and severity of relapses long-term. Research has actually shown us that when we start treatment early, we can lead to better outcomes and actually be able to help delay that disability and progression of disability. So a correct diagnosis not only helps us as providers tailor our treatments and specific symptoms associated with MS with our patients, but it also gives the patient a sense of peace and internal tranquility, knowing that there is an answer and that we are addressing all of these other very subclinical symptoms that these patients with MS can develop, like fatigue, spasticity, pain, or bowel and bladder dysfunction, and cognitive changes that can come with MS. When we obtain that really objective, definitive diagnosis, we can help address like any disease monitoring, and also in the long term prevent complications that might come with the disease. So for our next step, we're kind of reaching into our era of now, how do we diagnose or exclude other etiologies. So now that we feel comfortable, hopefully, about thinking about the clinical and the radiographical findings, let's focus on very common mimics that us as neurology residents or in practice will very often encounter. Our goal is to use some of our detective skills by way of that clinical presentation. So for this first presentation, and feel free in the chat to just put out any thoughts, anything that you find in the MRI that you think is key for us to really be able to differentiate what this disease could be. And we will start off with our 22-year-old male. He has no past medical history, presents with confusion and new right-sided weakness. So when you see them in the hospital, they say, or she has said, sorry, that, you know, about a week ago, the patient noticed that, you know, like started having like a headache, which was not normal, and then started noticing like some symptoms of like weakness in the right side. And then when you ask about any medications or any other notable past medical history, they really say, not really. About 2 months ago, maybe I had a cold that was pretty bad, but I just treated it with over-the-counter medications. But that was it, and they were no longer on any medications, even over-the-counter. So when you do their physical exam, you actually start to notice the right homonymous hemianopsia. You get some weakness in the right upper lower extremity, and you also get an upgoing toe on that right side. So when we look at this MRI, we first focus on that left image. So looking at that flare, we see that there's hyperintensities that are pretty asymmetric. We can call that they are irregular in regards to their borders, and we're involving that kind of left occipital, parietal, and dorsal frontal lobes. When we look at that image on the right, when we have contrast, the contrast really doesn't follow a specific enhancement pattern. It's very kind of just patchy and not really that clear. So what is this diagnosis? You will see in the next slide. This patient was ultimately diagnosed with ADEM, which is acute disseminated encephalomyelitis. So ADEM is actually just a very acute autoimmune demyelinating disease that causes inflammation of the brain and the spinal cord, and is usually seen following a recent infection, especially a GI or a respiratory infection, which in our patient's case, that was what happened, or even a vaccination. Symptoms will actually even develop weeks to months later, even after the patient has returned to their normal baseline from their illness, acute illness. And then what makes this different from MS is we made this chart to kind of be able to differentiate the key highlights that would point you towards ADEM. So first, thinking about age at presentation. Patients with ADEM are usually under 10 years old, as compared to patients with MS that we can see usually affects young adults and beyond. When it comes to the gender, ADEM actually has a predilection for being more common in males over females, which is the opposite in MS. And then from a clinical standpoint, the disease is monophasic when it comes to ADEM. We can treat it and feel pretty reassured that we will not have to deal with this again, as opposed to MS, where it's like kind of relapsing, remitting, progressive disease. And then thinking about viral triggers, like we mentioned for ADEM, we want to see if there's any history of any GI or upper respiratory infection symptoms in the past, or even vaccinations, but this is very rare to be in MS. For CSF, lymphocytic pleocytosis, and like Dr. Shah mentioned earlier, looking for those oligoclonal bands in MS. And then MRI, which is what really helps us differentiate this, is that there are normally numerous kind of large, like greater than 1 to 2 centimeters, asymmetric and poorly demarcated, what we call fluffy lesions, in those kind of deep grayer structures that can involve like our basal ganglia, thalamus, and more normally actually spare like the periventricular region. The recovery, thankfully, for ADEM is very good. The prognosis is good. And as we understand for MS, it's more of a chronic treatment. So for our next slide.
All right, thank you, Andrea, for that first mimic. I'll go into the next, and perhaps maybe we'll go through a couple of these and take a pause around 12:50 for questions. We've got several, and truly we could probably do this all day, but we do want to make sure that we get a chance to answer any questions that come up, but we've got some excellent cases. So for patient number 2, this is a 32-year-old woman who came to the emergency department after a month of hemibody numbness, and she also had some hiccups and abdominal pain. She actually first developed that left arm numbness about a month ago or so, and her primary care got some basic blood work, did an exam, but because on her review of systems, she reported some abdominal pain, she had some additional electrolyte checks and was finally referred to GI. When they evaluated her with these intractable hiccups, abdominal pain, the plan was for her to undergo an upper and lower scope, and they started her on treatment for GERD. Unfortunately, her symptoms got worse to the point where her hiccups were intractable. They were functionally limiting, and she therefore came into the emergency department for further care. At the time of her exam, she had poor vision in her left eye with an acuity of 2200, and then in the right eye, not all that much better with an acuity of 2100. She had decreased sensation to all modalities along the left upper and lower extremity, and she also had some left gaze nystagmus. I'll give you a moment to take that all story in, and then I'll point out a couple things here on the exam. This was the MRI that was obtained, and appropriately, given her hemibody concerns, neurology was involved. And these sequences are the flare sequences. On panel A, you can see sort of this T2 flare hyperintensity around the cerebral aqueduct in the periaqueductal gray. And then in panel B, the long panel on the right-hand side of the screen, there is a long intramedullary T2 hyperintense lesion. This is a T2 stir scan that's cut sagittally. That goes from around C2 to maybe even T1. It's about the whole span of the cervical spinal cord. So, depending on what y'all were thinking, this woman was diagnosed with neuromyelitis optica. There's a lot on this page, but we'll highlight a few important salient points here. One, neuromyelitis optica was previously, for decades, thought to be a subtype of multiple sclerosis. And then it wasn't really until the 80s where it was given that name of de Vick's disease to differentiate the degree of disability, the severity of illness that we saw with this subtype of demyelination versus regular run-of-the-mill MS, which is bad in its own ways. NMO, just to separate the two, and MS frequently involve the central nervous system. And so what we'll do with this lovely chart that Andrea has created is to go through the areas of involvement and the differentiating features between NMO and MS. Both can involve the optic nerve, but what's unique to neuromyelitis optica is there can be more bilateral involvement, whereas the neuromyelitis optica, whereas MS can often be unilateral. Maybe we had to switch those. And then for the severity, NMO is far more aggressive. The image that we shared on that first slide, I think, is one that sticks with me for many of my patients, which is almost this cystic demyelination that happens in the cord. There is so much inflammation and it is so dense that it leaves areas of void, of missing spinal cord tissue. And you can imagine just the degree of disability that may leave behind. The other items on the table here highlight the fact that neuromyelitis optica tends to be a longitudinally extensive involvement of the myelitis. So when I was highlighting that it was the entire cervical cord involved for this patient, that's really one of the key features, if there are greater than or equal to 3 segments involved. Transverse myelitis is pretty frequent. In fact, neuromyelitis optica is in this group of diseases thought of as opticospinal syndromes, which is that the optic nerves and the spinal cord are preferentially involved. Whereas in MS, we have far more brain parenchymal involvement, and the transverse myelitis is less frequent. And then finally, there is a blood test that is fairly specific to neuromyelitis optica, which are these aquaporin 4 antibodies. Aquaporin 4 channels are ubiquitous in the body, and aquaporin 4 has this specific or specificity for the water channels that are around the brain lining that go in and out of the spinal fluid flow. And so that periaqueductal gray, the periventricular lesions, even the optic nerves, areas that are bathed by that spinal fluid flow tend to be more preferentially affected. Just so you all know, to make a definite diagnosis of neuromyelitis optica, to be seropositive is the phrase we use, these diagnostic criteria are elucidated here. More often than not, because the antibody testing can take a little while to come back, we often are dealing with a seronegative status, which is that someone comes in with a right clinical story, but we don't have the antibody testing back yet. And then recent thought in our world and as neuroimmunologists has really led to this heavy suspicion of a diagnosis of seronegative neuromyelitis optica, because there are other mimics in these opticospinal syndromes that may not be MS, but may warrant completely different treatment options. So if you're seeing optic nerve or spinal cord involvement that's debilitating, that's longitudinally extensive, that's bilateral, think NMO. On to you, Andrea.
That's good. So the next case is actually one of my favorites, and it was a patient that I was being consulted for in the hospital. It was a 40-year-old female who presented with hearing loss on the left, double vision, a left facial droop, and a headache. She actually reports that her symptoms began about 2 years ago, and she noted that she just had kind of bilateral numbness and had some weakness as well in the legs. She went to go see her primary care doctor, who actually did recommend getting an MRI, but unfortunately the patient moved states to North Carolina and was unable to ever really get this done. She noticed that about a week before she presented, she started having left ear either ringing or decreased hearing, but didn't really think much of it. But then she started also kind of having double vision, especially when looking to the left. And then her family even started to notice that her face looked different when she took pictures. So on her exam, she had multiple positive findings. So she had an inducible kind of horizontal diplopia and subnystagmus with left gaze. When we did our sensory portion, she was not able to really feel bilateral lower extremities. And then she also was weak in the bilateral legs, 4 out of 5. And then she actually had positive Babinski's and Hoffman signs. So as we look at this MRI, some of these will be videos that we can kind of flip through. So the first one on the left side, we can see that it's an axial MRI T1 with contrast. And what really starts to pop out is that leptomeningeal enhancement that we can see involving that inferior, middle, and posterior cranial fossa. And especially when looking at the other images on the right, we can even see that it extends into that pituitary infundibulum and, really highlighting how much lighting up there is. There really wasn't any other, lesions that were enhancing as much as just that leptomeningeal, just generalized enhancement. So thinking about what could cause such as diffuse enhancement, that probably was what kind of knocked out multiple cranial nerves and caused this constellation of symptoms. If we can take a couple of seconds to just think about the images, and then ultimately our diagnosis for this patient after additional testing and confirmation, which is ultimately diagnosed with neurosarcoidosis. So what is neurosarcoidosis? We'll take a step back and just talk about sarcoidosis, which is just a multisystemic inflammatory disease. It's characterized by us developing these granulomas, which are non-caseating, and they really can develop in any organ, but specifically like to target those lymph nodes, the lungs, eyes, and the skin. And about 5 to 10% of the patients with sarcoidosis, when they have central nervous system involvement, that is when we can actually call it neurosarcoidosis potentially. And this is due to the kind of those granulomas infiltrating the different regions of the central nervous system. Most commonly, we will see kind of cranial neuropathies, with the facial nerve being the most common cranial nerve affected. We can start to see myelopathies or radiculopathies, and leptomeningeal disease, which is what we saw in our patients, is usually one of the very classical MRI findings that we can see. As we see on the bottom, with kind of giving that contrast enhancement, everything just kind of really lights up. When we think about the, criteria or concern for, is this a patient that maybe could have neurosarcoidosis? There is a criteria that was developed, and it's a 2018 kind of consortium consensus. And the key here is that we have to really put together 3 main things. The first one is using the clinical presentation that suggests that this could be a neurosarcoidosis presentation. We must make sure that we also exclude any other causes that can be commonly seen, such as infections or malignancies, especially thinking about when we have that kind of leptomeningeal enhancement, that it's not in the setting of a malignancy. And then when it comes to being able to really give that definitive, probable, or possible diagnosis, we have to obtain some type of biopsy. So normally the way we do this is if we are suspicious for neurosarcoidosis, we start with just obtaining a chest x-ray. It'll be helpful to look for any possible like hilar or mediastinal like lymphadenopathy. Then this will be followed by a CT chest, which you can see in this bottom right-hand image. This is helpful for two things. Not only is it kind of also very confirmatory for looking at localization of that lymphadenopathy, which usually likes to go in the apices of the lungs, but it also can be a very good site for surgical biopsy. Now, as we see on the right-hand side with that table, in order for us to really be able to make that definitive diagnosis, the positive CNS pathology must come from, like I said, from a central nervous system source. And we actually see just a very small snippet of what that pathology looks like at that bottom right. So if you look at the center, you're going to see kind of this organized cluster of inflammatory cells that are usually characterized by being a central core of T cells, macrophages, and like multi like nucleated giant cells. And then these are kind of surrounded by like epithelioid cells and tissue. And this is very classic for that non-caseating granuloma.
Well, thank you, Andrea, for going through that with us.
Yeah.
In the interest of time, what I might do is take a break to see if there are any questions or specific diagnoses that you all want to hear about. We've got several other cases as well. And if nothing comes up in the next minute or so, I'll go on to our next case. I think case-based learning is really interesting. And my next case that's up is a rare one. So it's a fun one to talk about. So for our next case for today, I've got patient number 4. This is a 40-year-old woman who is presenting with a week of headache, personality changes, and frequent falls. She has a history of type 2 diabetes and reflux, and she came into the ED with a week of headaches and those falls. The family reports that for the last week or so, the patient has been acting childish and doing things inappropriately, like calling out people's physical features or not pulling up her pants after using the restroom in public and coming back out. And at times, she has been complaining of headaches, which is not really her typical. And then one of her family members adds that she's been walking around as if she were intoxicated. On exam, you're going in to see her in the emergency department room as the neurology resident. You have a patient who's irritable. She's difficult to examine because she really doesn't want to cooperate with the exam, but you can see her moving all of her extremities fairly well, anti-gravity. She does try to get up and walk around the room because she thinks she has places to go, and you can see how significantly ataxic she is. And finally, with the family's assistance, when you're able to get that reflex hammer and check some reflexes, there's some generalized hyperreflexia. She has upgoing toes bilaterally, and despite not being able to do a formal cranial nerve exam, there's no obvious facial droop or restricted gaze or nystagmus that you can see as she looks around. With this story and this subacute story of a week of really having these worsening falls and her encephalopathy that you see on examination, an MRI is obtained that you see here. And one of the challenges as a neuroimmunologist I run into is that there is a longstanding thought that corpus callosum involvement means multiple sclerosis. So you can see here, I'll point out, we've got these areas of T2 flare hyperintensity in the corpus callosum. But a lot of those typical findings that Andrea pointed out aren't there. I'll give y'all a moment to think through this one, and then we'll go to the next slide. All right, so what are we dealing with? This is Susac syndrome, which has this triad that's classically written about in the textbooks of encephalopathy, of sensorineural hearing loss, and branch retinal artery occlusions. The thought is that it's this small vessel vasculopathy. There's more and more literature that suggests that it truly is a small vessel vasculitis, which can lend some credence to how it can be treated. But it typically affects folks in their 3rd to 5th decades of life. That should sound familiar. It typically affects women more than men. And all 3 of the features that you see on the slide do not need to be present at the time that someone presents. And so because you're often dealing with 2 of 3 or 1 of 3, diagnosis is really challenged. And it is those imaging features that we often rely on to say, this looks different than our usual demyelinating disease. Let's think harder. Typically, the course is acute to subacute, where there might be vision changes or might be these falls that come about. And then the encephalopathy is what really leads people to seek out medical care. But what I'll point out about the imaging that y'all saw on the last slide is that feature. Someone once described it to me as if someone took a melon baller to the corpus callosum. I hope that never happens to anyone, but I think it's a good description where someone takes out these rounded lesions, and that's what's left behind, these discrete in the corpus callosum only, not really extending beyond the boundaries of the corpus callosum, areas of ovoid T2 hyperintensity or round T2 hyperintensity. And I think that's a great way to remember it. So if you see changes on a brain MRI in the setting of encephalopathy or vision changes or hearing loss, and an MRI has these kind of restricted features to the corpus callosum, start thinking about Susac syndrome. Though the triad's there, it's often with our ophthalmology colleagues that we can look for the vasculopathy on retinal imaging, and that's where the diagnosis is made. As I said, there's some debate about whether this is inflammatory or not, but it is an interesting and rare diagnosis. Andrea, over to you.
Sounds good. So I see that we are running a little bit tight on time, so I will make this case pretty quick. It is a 45-year-old male who gets brought in actually to the clinic for just a 1 week of right hemiparesis. He's brought by his daughter and his wife. They both report, he has a history of stroke, so he's always been just a little bit weaker on that left side. But just over the course of a couple of months, we've noticed that cognition has kind of gotten down, like he's not able to really take care of himself. And we noticed that he started having this weakness on the right, that he wasn't able to really hold his walker to walk. So as we start looking at this image, what I think initially will stand out to us, and I think they are also videos, if I'm not mistaken, is we'll start to kind of see that we have this like very confluent, like hyperintense, like T2 hyperintensity is just kind of everywhere. Like what we think about in like that kind of microvascular distribution, just affecting like all areas pretty symmetrically bilaterally. And then when we look at this axial image right in the center, I think what's very like interesting about this is that we have the anterior temporal lobe that seems to be pretty involved, and we have relative sparing of like that occipital and like posterior region. So when we think about this guy's like fairly young, he really doesn't have any significant past medical history, but yet he keeps having recurrent strokes. He keeps having, kind of this cognitive decline. So what are we starting to think about? Family did ultimately disclose at one point that, yeah, his father actually had similar, kind of decline pretty early on in his lifespan. So that putting everything together, as we go on to the next slide, we will see that this patient was actually ultimately diagnosed with CADASIL, which is a cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So it's a mouthful, so we normally just say CADASIL. What we want to understand, and just how the name implies, it's autosomal dominant. It's usually due to a mutation in a chromosome 19 for that Notch3 gene. And it's really characterized by these recurrent lacunar and subcortical white matter ischemic strokes. So a patient that's having just recurrent strokes and we cannot figure out why. Usually this is seen clinically with patients that come on with very early onset dementia in that kind of like young and middle-aged adults. And as we pointed out in that old other imaging, when we look at FLAIR, we'll see very like T2 hyperintense lesions kind of throughout, but most notably, like we'll see those anterior temporal lobe involvement. And I think all of that kind of helps put the characteristic together, especially if this is a patient that doesn't have any vascular risk factors. So I think that was a quick one, so we can maybe
Well, good. No, thank you, Andrea. I think that was fantastic. And what I'll do is I'll skip over our next patient. It's an interesting one, but we have a question which I think is one that I love to talk about, and maybe we can end our demyelinating disease talk here. So we'll skip over clippers. We'll keep those mimics in mind that Andrea put together this lovely list. And even as recently as 2 weeks ago, we were teaching each other about Bing-Neal syndrome. So I think if any of these sound unfamiliar, certainly look it up. I think that's what makes the field of neuroimmunology so fascinating, as you have to really know your diseases and continue to learn about new diseases. Well, with that, I'll read out loud the question for everyone else here, but the question is, how do we overcome the challenges of reported transient focal sensory or motor deficits that have no corresponding MRI lesions? Do you chase these symptoms with a higher Tesla MRI or modify or start a disease-modifying therapy? And do you treat PIRA? For those of you who may not be familiar and sort of outside of the scope of this talk, but it's a great question. PIRA is progression independent of relapse activity. And again, it's a hot topic with lots of science behind the radiographic features and what we do in the demyelinating disease biomarker world with MRIs primarily. I'm going to step back and tell you that I think PIRA, that progression independent of relapse activity, that diagnostic phrase we use, is really validating to patients. I shared with you all a story with my secondary progressive patients where they look at me and say, I feel different, but you're telling me my exam's pretty stable and the MRIs are unchanged. You suggest something really important here, which is that not all MRIs are perfect. And in fact, even if you use the best Tesla MRIs, which around here commercially it's 7 Tesla MRIs, with technical changes, you may still be missing things. And so you can't always be 100% certain. So again, listening to the patient is always step one. Did the story really fit? And these days, I'll often treat someone for a relapse based on whether they had that crescendo, decrescendo that Andrea spelled out, of symptoms that came on subacutely and went away. Often, to me, that's a sign. If there are new symptoms that the person's never experienced before, it's a sign to start having a discussion about switching DMT. However, to answer your last question, I don't treat PIRA. I don't think we have any FDA-approved treatments at this time that actually can slow down that progression independent of relapse activity, though many are looking. And so to me, when someone fits the bill for that type of neurodegenerative part of MS, that secondary progressive part of MS, that's a sign to me as a physician to step in and do more supportive care. Sorry, Andrea, I sort of took over on that one, but did you have any other thoughts and how do you feel about it?
I really like that approach. I think it's always very important to we don't like to dismiss symptoms, even if we don't have any objective findings that tell us or support that this could have been something real. I am also along the game of we make sure that there's nothing else in the history, because I think it matters so much. Just sitting down with the patient and asking about, did something like this or something similar happen in the past? Anything that can really make you really put on that kind of detective hat and put things together is so helpful.
That's a great way of putting it. Well, I know we're right at the top of the hour and we've got a group full of busy trainees. So with that, I will thank you all and turn it over to Andrea to do the same for joining us today for this webinar.
Yeah, thank you everyone for joining. I feel like Dr. Shaw and I really enjoyed putting this together. We've learned a lot and we continue to really enjoy watching everybody else's lectures and just learning and kind of stepping outside of the box and seeing how other people approach certain things. So thank you everyone for here today.
Perfect. And thank you so much again, Dr. Shaw and Dr. Linares. It was so great having this talk. I learned a lot and I'm not even in medical school, so that was fantastic. I would also just keep in mind too that we do have a couple other things to continue the talk in neuroimmunology. Dr. Posas will be with some panelists later this month talking more about multiple sclerosis. I put that in the chat and we hope to see you there. Thank you everyone and have a wonderful day.